Assalamu alaikum, everyone, and welcome. Good morning, good afternoon, good evening, depending on where you're joining from. So, on behalf of the APPNA MERIT subcommittee, I welcome you to this series of webinar that we've been conducting on healthcare research and innovation landscape in Pakistan. And today we are welcoming you with the topic of research understanding through critical appraisal. And research understanding through critical appraisal is a very uh, important and pivotal topic in clinical research. My name is Sarfraz Hasni, and I'm a rheumatologist and director of lupus clinical research at the National Institutes of Health in Bethesda, Maryland. And on behalf of APPNA MERIT Committee, today we are welcoming Dr. Muhammad Usman Aamir. And Dr. Muhammad Usman Aamir is a consultant rheumatologist at Galway University Hospital in Ireland. He is currently working in that capacity since 2001, so he's been there for quite some time. And he worked in Avicenna Medical College as associate.
I think Dr. Sarfaraz lost your connection. Maybe Dr. Usman, you can start.
Okay, okay.
Tell us about yourself, later introduction. Thank you.
Thanks very much. Thanks very much from Umar Hayat, and thanks very much from the APPNA MERIT and Sarfraz Hasni for inviting me for this talk. So, my today's topic is the research methodology through the critical appraisal. The ground situation here in Pakistan, it's will be predominantly the audience from Pakistan and also in the other subcontinents as well, other continents as well. So the situation is there are approximately 20 medical colleges in Lahore. There are the research methodology workshops conducted by the CPSP for the PGs and for the faculty supervisor also. And almost there are all the APPNA webinars, they are conducted by either by the people from the medical education background or from the community medicine. There is nearly no input which I say while living over there by the clinicians or from the clinicians. Even the CPSP workshops, they are conducted by the community medicine. Though I have not attended the workshop, but I looked at their content at that time. And the community medicine and the medical education, they don't have the clear idea about the clinical medicine. Similarly, when you look at the presentations in the conferences, in that you don't see the appraisal of the paper. They just write down the contents, don't use the figures and the graphs in their presentations. So therefore, I decided to give this talk on this topic. So here is the critical appraisal. What is this? It is the process of systematically weighing up the quality of the literature. And it is a balanced assessment between the benefits and the strength of the research against its flaws and the weakness. It can help you to inform about the decision. And I think it's the most important skill which a clinician needs to be practiced, because it helps you to understand the literature, to use it in your clinical practice and make the decision. So how the clinicians, they make the treatment decisions. The data are the knowledge comes either from the clinical trials or from the registries, and the real world evidence, they are nearly the same. Meta-analysis, and now we're using the network meta-analysis. And there is a difference between the meta-analysis and the systematic review. And again, in the meta-analysis, there is a difference between individual patient meta-analysis and the summary statistics. Nowadays, there are indirect treatment comparison as well. These are the new technique where the evidence will be coming in future. So areas for the scrutiny regarding the critical appraisal was, you will look for the study aims and objective, study design, study outcome, inclusion and exclusion criteria, data collection, and there will be a formal presentations of the results and the interpretation and discussion. There is a lot of talk already done by the hierarchy of the evidence. Traditionally, it used to be the case reports, case series, randomized controlled trial, but nowadays there is a new evidence-based summaries. It's the new addition into that, and on the basis of that, they write down the evidence-based guidelines while critically appraising that. Though at the tip of this one is the Cochrane systematic review, still that is staying on that. So basics for every research, every study or every project, there you need to make a clearly formulated question that you want to address in that. Then you will look for the good study design, though there is no perfect study design to answer any question. There is a mix-up of the design which are used to address that question. Then you will get a representative sample, and inference on the base of the sample, you will derive and apply it on the population. So this is the most important thing which I have learned from, I knew it before, but it was repeatedly coming up in the previous webinar that I want to do a research, I want to do a research question. So this area seems it's very hard, but if you know how to develop a research question, it's very easy then. So first of all, you will find out the topic, how prevalent is this topic in your area where you are staying or where you want to do the research. Then you have to do the literature search for that. And while doing the literature search, you will come across a lot of questions in that. In that, you will decide what is the major outcome that is called also the dependent variable which you are interested in. Then there will be an independent variable that can be a risk factor, these things which you will develop. And depending upon that, you will find out the relation between that. What group of population you have to be selective, therefore inclusion and exclusion criteria will come up. But you need to specify your research question. You have to narrow down the research question because that is the most important. Now, what sort of questions they are? So there are different ways to define the question. So I am going by a different way because normally they talk about a study design first, and then after that they discuss the question. But I say that there are the questions which are for the public health and health researchers, and there are the questions for the clinical one. Public health, they are dealing with the screening. So screening is that individual who is at risk. The risk is not the same as the diagnosis. So screening, etiology, and prevention, it also comes mainly in the public health domain. But once a person has the disease, after that, the outlook after the diagnosis is called prognosis. So in clinical research, there are the diagnostic modeling, there are prognostic modeling, and in that come the therapeutic trials or randomized controlled trials. And therapy can be not only the drug, it can be a technique as well. It can be other modalities. Then the cost-effective and economical analysis. If you define accordingly, then you will be able to formulate your research question in an easier way. What are the sources of research problems? Particularly in Pakistan, the journals, the faculty people, the PGs, doctors, they don't read the journals. But I think journals, they are the very rich sources of the good questions. So you have to develop this skill. It's not an innate skill, it's an adaptive skill. So you have to work hard on this and you can find it out. So for that, you will have to see the earlier research as well, depending upon the literature search. When you do, you come across different ideas. They are given in the discussion section as well. So you have to link yourself with the journals. Without that, you will not be able to develop a research question. I will give you a practical example later on during my talk. So once you have a question, that will be, obviously it will be broad initially, but then you have to narrow the question. That is the key to that. While reading a medical article, and give enough time to think about the article, identify the central question. Frequently it's in the beginning of the abstract, or it's in the beginning of in the first paragraph, in the beginning or in the end of the introduction. Think about the answer by yourself, that how will you answer this question? And ask yourself repeatedly. Compare it with the author's plan. Then the article, sometimes you read it on first time and you think that it's very interesting, but later on you find that it's just the feet in the clay by the third reading. Therefore, rethink about that as well. Here is an article which I looked at, that the assessment of feasibility while reviewing the literature, because it's my habit, I'm searching different journals. So I came across in the JAMA network, assessment of the feasibility and cost of hepatitis C in elimination in Pakistan. I discussed with a lot of gastroenterologists while over there. No one was knowing about that. So they took it from the open data, what is available in that, and they put the prediction model on that, and they established that. So this is one example. While doing a research, fundamental question is it observational study or the randomized controlled trial? That is the main question, because people, they go are the teachers in the research teaching, they go for the observational study by case control, cohort study, and this. But what is the main difference in the observational study or the randomized controlled trial that will help you to make a project? For example, randomized controlled trial, they are very rare in Pakistan. So what is the opportunity over there? Observational studies. There are a huge number of patients. You can collect the data, you can do it. So the question comes, efficacy, can it work? So it is in the randomized controlled trial. Effectiveness, you see it, does it work? Because you will see it in the real world. Then its efficiency, is it worth doing? That will be cost effective, cost to utilitarian, and cost benefit ratios. So there is a long discussion going on between randomized controlled trial and observational studies, that how much evidence or how much effect we will get it from the RCT or observational studies, and how you will make a decision based on these RCTs or observational studies. So this was the article, randomized controlled trial analyzed as observational studies to come up with some of the limitations. Then observational studies going beyond the boundaries of randomized controlled trial. Here, it is published once that 56% of the authors of the observational studies, they recommend in the guidelines. So the evidence directly comes from the observational studies around 56% or 60%. At the same time, there is a question asked, as I said that numerous times, can we trust the observational data for clinical decision making? There was another article where in the cardiovascular journal, which I read a year or 2 years ago, the heading was the last nail in the coffin of the propensity score analysis. So the meaning was that we do not should rely on the observational study. So whenever if you know the technique, what is the weakness and strengths, then you can go ahead for that. So but I describe again the traditional one we have gone through in the previous webinars about the descriptive, I say it's descriptive studies, which are called case report, case series, cross-sectional surface, and correlation. Analytical studies, they are the observational real-world data and registries, and you can do the case control and cohort studies in that as well. Then comes in interventional trials, and I put it as well diagnostic studies. So these are some of the for the public health, like serial cross-sectional surveys, longitudinal design, administrative data, which will be present particularly in Pakistan in the medical superintendent's office, and there they can take it, and ongoing research cohort if anything is going on, and then electronic record, which doesn't exist in Pakistan. So here is the from the FDA. There is a lot of struggle going on to give the emphasis on the randomized real-world data analysis for the regulatory decision making, because Traditionally, it comes from the randomized control trial, but they are trying to get more analysis, good analysis, which can overcome the weaknesses of the real world evidence. And so it's a review article. It's worth reading that. Here in this, there are different studies which they use it by the real world data analysis. Then they did the randomized control trial. They're done nearly at the same time, and they come on the same conclusion. But still, question always lies that should we trust on the observational studies or not? The famous one is in the rheumatology was the fiboxostat, which showed in the randomized control trial that there is increased cardiovascular mortality, and they were seeing in the observational studies as well. This is for the randomized control trial. This is from the New England Journal of Medicine. There is a new journal with the name of Evidence. They are again improving the trial design. Previously, it was traditional randomized control trial. Now they are taking the externally augmented RCTs, where they are taking the other sources for the controls as well. Hybrid randomized control trial, and they are recruiting the patient from the existing source that will not be included in the trial, but they will using it externally and they analyze it. And the last one within that is the non-randomized comparative effectiveness study. They will use experimental arm will be existing external source, control arm will be existing external source, and then they will use the propensity score analysis to overlap the weighting and matching to mimic like a randomized control trial. So there is a lot of new advances coming up in the analysis of particularly the real world data. So designing the study, again, formulate a research question, what is known on your unknown in your field. Questions are descriptive, but analysis are comparative. So analysis will be is prevalence high in some characteristic, is survival high in some people, in male or female, or in certain subgroup of population. So you will do this thing. I will not be going into detail into exploratory or the descriptive. I will just mention about the descriptive one. Exploratory, it's you don't know about any situation and you want to explore that is called the exploratory. But descriptive study, why I put it in that, the most of the studies published in Pakistan in the journal of CPSP, in all the journals, in journal of this JPMA, and in all the journals, they are the descriptive studies. None of them are very few, they are the analytical. So if you look at the journals, they are just addressing the questions of who, what, where, when, and how, but not why. So you need to we have to go towards the answering the question why what is the causality among them, because these questions they do not address the causality between the two factors. So for causal or experimental, you have to do the cohort studies and you have to do the randomized control trial. In that, you will have to use the exploratory analysis. I will come back in detail. This is the design which you can see it. Every presenter present with the different figures. There are a lot of figures, and every journal gives every so often they are presenting these. Why I picked up this one is because in our situation, we are using only in Pakistan descriptive cross-sectional studies. So they are the diagnostic studies. None of them, the other experimental or quasi-experimental or the cohort or the case cohort study or the case control study, we are not using that. So descriptive cross-sectional study, with that, our limitation is who are doing the research, they can use only the descriptive analysis. They cannot do the analytical analysis. Again, there is a lot of studies, they come with the correlation, but there is a difference between the correlation and agreement. Correlation you come across with a lot of the diagnostic studies, but in the diagnostic study, there doesn't exist any correlation, because in correlation you cannot address the cause and effect relationship. Rather, you can do the agreement studies. Agreement studies, what's the difference between them? Correlation is between two variables. Agreement is between the same variable. So agreement, particularly it's more familiar in the people. They are more familiar in diagnostic and in radiology and what we call it in histopathology, because you can ask the different radiologists to interpret the imaging. You can address the agreement between them. Similarly, you can address the agreement between the different histopathology depending upon the early to the severe disease as well. So you can address inter-observer or intra-observer relationship with that. So this I think that you need to concentrate on the agreement studies if you are working in the radiology or in the histopathology, because there are a lot of questions comes when I was attending the webinar from the histopathologist or the radiologist that how we can do the study or how we can engage in the studies. So diagnostic studies, I will talk about with the example. So there are two design in that most of the time. One is the cross-section, other is the case control. We heard from in the previous lectures that one of the speaker, a few of the speaker, they were saying that this has a high sensitivity and high specificity. These two measures do not go hand in hand. They go opposite to each other. If sensitivity is up, specificity will be low. If specificity is up, its sensitivity will be low. And sensitivity and specificity and predictive value, a lot of people, they don't know. Sensitivity and specificity, it helps you to decide which test to use. Predictive value helps you to decide which patient to treat. Sensitivity and specificity, you can address it from case control study. You cannot address predictive value from the case control study. You have to do the cross-sectional study. All those people who are the suspected, not the cases and the control. So from there, you will go ahead for the predictive value. And the third one is the role of prevalence. I will come up with one of the slides later on in the talk. So here is the article when I was doing my first workshop in Pakistan. This was the article published, Rheumatologist score in acute appendicitis in the College of General, published in the College of General and GPMC, Journal of CPMC. And it showed that there was the sensitivity and specificity of this score was 88 and 67%. But in this study, they included 267 patients. Sensitivity was 96.7%, specificity 93%, negative positive predictive value 94%, negative predictive value 95%, accuracy 95%. So what will you conclude for this? It's a highly sensitive test, at the same time highly specific, that and it will give you very, very good accuracy. And what was presented in the tables, you look at that. So if you dig out into that, the total number of patients, there were 267. Histopathology and the Rheumatologist score was positive in 152 and normal in 115. So when you look into that, this was not a case control, this was not a cross-sectional study, though they said that it is a cross-sectional study, but it was a case control study. So what has done, it has inflated the whole result. Therefore, it is showing the same sensitivity, same specificity, same positive and negative predictive value and the accuracy. So honestly speaking, if you look at this article, you can throw it in the bill because it does not give you any conclusion. Coming back to in 2022, when I was preparing for this, I came across with this study. How many number of patients they included? 40 patients. It's the same cross-sectional design. How did they analyze that? If you are working in Lahore, you want to do a study. So in 40 patients in a single night, you can include for the acute appendicitis or for Rheumatologist, modified Rheumatologist or other major mass. So you can include in one single night. You don't have to wait for that. Only thing is you need to have a good statistician, discuss with him how I can do that. Here are the results. So mean modified, the Rheumatologist score was 9.7, and with the plus minus mean and the standard deviation of 2.1, and it ranged from 7 to 15. Rheumatologist score, what the area under the cover in that was 0.9. Confidence interval was there. But if you look at that, the diagnostic sensitivity and the specificity and the predictive, all these value, this in the modified among the 40 patients, though if we compare it, the sample size is too short for that as compared to 267 or 64. So it gives us a sensitivity of 70%, specificity of 100%, positive predictive value of 100%, and negative predictive value, because the sensitivity is low, so negative predictive value is very low. So that gives you a real picture that this has been conducted in a very nice way and they know what they are doing. It's not defined by the statistician. It's not defined by the what we call false study design. So it's a real cross-sectional study where you have the suspected patient and you have done this analysis. So you need to understand that if you want to design a diagnostic study, you need to read the other diagnostic study. You are going to get this. You will learn this by reading articles. If you're not reading the article on diagnostic measures, you do not understand that you cannot design a good study. Now, the role of prevalence. This is the article which was published when the COVID was at its peak. Everyone was saying that in Pakistan particularly and all over the world, yeah, that you need to check measure the COVID test in the asymptomatic population as well. I came across this one. And there was no discussion at that time at all about this, that prevalence has the role in that. So it was from the McGill University, published in Annals of Internal Medicine. It says that if the prevalence of the disease is 5%, the specificity of the test is 95%, there will be a 50% of false positive rate. So it means if you are doing the asymptomatic population, your false positive rate will be around 50%. So you have to log down all those 50%. So I discussed with a lot of people, and in Pakistan there was no discussion. And as with all of the world, they were talking about at that time the false negative rate of 30%. You can see the article in New England Journal of Medicine at that time. It came up on the surface when Kamran Khan, our cricket team, was going to England, and Abdul Hafiz, our famous cricketer, he got the positive result. And then they asked our health minister that why it has come back positive. He was talking about the assays, that they are using a different assay, and this is the problem with that. But it was the problem of the prevalence of the disease. They were asymptomatic. So you need to know when you are doing doing the diagnostic study, you need to find out whether you are doing in the primary setting or whether you are doing in the tertiary setting. So now there is another regarding that. This article, it's published recently as well. So it says the efficacy of multiple biomarker NGAL, KIMI, cystatin C in predicting pregnancy-related acute kidney injury. So predictor models and for the diagnostic models, you cannot use simply the ROC curve. You have to do this is the figures which are shown over there. You have to do the discriminatory and calibration at the same time in prediction modeling. Because the difference in that is, if in the prediction models, when you're using that, the area under the receiver operator curve or AUC area does not go beyond 80 or 0.8 or 80%. So in diagnostic, you need a higher area, because if some test has an accuracy of 80%, it means that 25% they are the false positive or false negative. So you have to address that. So that's a useless test if there is a 5 out of the 1/5 are the negative. So therefore, you have to do the discriminatory and calibration analysis in the prediction modeling. And as you see in that, there is nothing over there. It's just they put the ROC curves. So it means if you want to improve your understanding, you want to improve your further research, you have to read the literature. Without reading that, you will not be able to go ahead. So this was about the diagnostic test. I will give you now an example of cohort studies. This is the article published recently in October in last year. I was preparing for the workshop, for a lecture. It says that it's a real world observation study, apixaban versus rivaroxaban in patients with atrial fibrillation and valvular heart disease. If you are searching for your own question, if you search this article, you will come across a lot of other studies. In that, they took the data from the January 2013 to December 22. So it's a large called a real world data or the good observational study. Now, similarly type of question you see in Pakistan. This is a study published in local journal, and it's from the academic people. It's not from the PGs, it's not from the junior registrar, it's from the professors of the medical colleges. And I'm not saying about this one particularly, but all of the faculty people, they have the same knowledge and similar like understanding. Here he is comparing effect of rivaroxaban in stroke prevention in patient with atrial fibrillation due to valvular heart disease. How many number of patients? 36. What they have used, just the descriptive statistics. They switch the patient from warfarin to rivaroxaban, and they want to establish. Rivaroxaban is used, apixaban is used long time before that. If you have the habit to read the literature, you can make a good design, or you can make a better design. You can develop a better analysis for that. So my emphasis, therefore, I was concentrating on critical appraisal, because with it, you will not only improve your observation, you will not only improve your study design, you will improve your clinical knowledge as well. And you can use it in delivering a lecture or in everyday clinical practice as well. Now I will come back to the randomized control trial. So what I ask a lot of the doctors who have worked with me, that what is the most common design for the randomized control trial in recent times? Is it the superiority, equivalence, or the non-inferiority? It is the non-inferiority trial. Why? Because we have now in nearly every specialty, we have the standardized treatment. We cannot use the placebo. So we have the drug to compare with the new drug. So non-inferiority trial, they are very popular. So there are some methodology issues with that. And one concept the people, they don't know in medical field, particularly back home in Pakistan, that you don't need a drug to do a trial. You can do a physiotherapy. You can do any intervention. For example, you are for a back pain patient. I was discussing with few of my colleagues that physiotherapy, epidural, and the surgery they are using in the spinal stenosis patient a lot of time over there. So what they do, they use 3-4 measures. They will send the patient for physiotherapy. They will do give the epidural. They will inject the facet joint as well, and some they will go for the surgery. So if you want to do, if you want to compare with them, you can compare physiotherapy with the epidural. So it can be any measure which you can use it. Similarly, in surgery, one technique you can compare it by designing a randomized control trial with the other well-established design. So you have a lot of opportunity if you know the proper study design and how to conduct that. The only important is how will you define the minimal clinically important difference. There are a lot of articles, nearly every journal they're writing frequently, and predominantly in rheumatology as well. There was a recent article and we took it from the diabetes mellitus, and in the cardiovascular research, considering the diabetes mellitus. So is that we are using the same minimal clinically important difference in rheumatology as well and in other. And one more thing is that in this trial, you are using the composite measures. So I did not put what are the outcome like surrogate markers, hard outcome, composite outcome, because that need a separate lecture. So in that there is a one-sided hypothesis. You cannot claim superiority. If you want to complain superiority, you will have to address before in the planning time, and you need to mention that. So here is again a study which is published recently that in the multivessel coronary artery disease, will you do the primary stenting, or you will do the secondary stenting? This is the randomized control trial. In Pakistan, in very few centers, they are doing the primary angioplasty. Most of the people, they are getting the secondary angioplasty. So if you want to do design a non-inferiority trial in Pakistan, there is no problem for the patients. There is no problem for recruiting those patients. And you can do the real world data as well, and you can do design the non-inferiority randomized control trial as well, because both of these measures you can do it over there. Then you can analyze it, and it's just published on 5th of March in the Lancet. So you need to, if you are not reading the literature, you cannot develop your research question. So it is worth reading it for the particular for the cardiologist. You will get the sense of the non-inferiority trial as well, and you can use it in your setting. And to recruit the number of patients, it's here is 764 in one group and 761 in other group. Sorry, I know the people in one of the major hospital. He has done at least 200 angioplasties in a month. There is a huge number of patients in every center, including Multan, Bahawalpur, in Faisalabad, in Lahore, in Karachi, in Peshawar, in Pindi. So there are a huge number of patients. What we need to do, we need to do a combined effort. We need to first of all increase the understanding of the faculty and the registrar level and the NCHDs. So this is the primary analysis and the subgroup analysis. I will come up a little bit about that. This is the article which was published recently from the Aga Khan University and Shaukat Khanum Hospital. They were about the hepatocellular carcinoma. When I went into 2014, there was a heading in the newspaper that there are 6 lakh people in Pakistan diagnosed every year with the hepatocellular carcinoma. So there are a huge number of patients over there, and what we are doing is we are doing a descriptive analysis. Just we did a Kaplan-Meier curve on that. Total number of patients were 59, disease occurrence 42, mean follow 2.4 year, median survival 45 months. We did not use really a Cox proportion hazard model for that to develop that. We could have done, we can do from this study, we can do a case control design, use this as a cases and take the control from the other admitting in the same hospital. So if we know how to design that, we can do a better study. So here I will talk about a little bit about the analysis, because for the junior NCHDs, they always are stuck with the statistician when they are going to the CPSP to get the approval for their dissertation. So that's the most fear which the NCHDs are, which the PGs face over there. So I will define it. There are 3 types of analysis. One is univariate analysis. It means only one variable is included. It is the mean, mode, and median percentage and the proportion, and it is presented in the demographic tables where there are the baseline characteristics that are the variable which you have to collect, and you will present in that. So every study, whether it's 100 patient, 40 patient, or 100,000 patient, they will start with the univariate analysis. Then come the bivariate, where there are 2 or more than two variables. So most common test between them is the t-test, which is also called Mr. Mean, and the chi-square test for proportion, and you can do a Fisher exact test. And I will give you here is this bivariate analysis, which test can you use, and you don't have to remember that you have to know each and out of this one. You just when you want to apply it, you can tell them that this test I will apply depending on my variable, and it depends upon the unpaired data or the paired data. So you can do it, and that's the easier. Then the software you can use it and do it. Here is again it's for the correlation, that what will you do for the Spearman and the Pearson correlation. Next one is the multivariate analysis. I know there is a mindset between the CPSP graduates, which is injected from the CPSP, that you should not go for the multivariate analysis. You will go for the study which has the least number of variables. That is I would say that is the worst advice which the CPSP is giving to them. We are living in the multivariate world. We have a lot of risk factors, and we need to collect those and adjusting those risk factors. And we need to learn the skill how to use the multivariate analysis. Sorry. So these multivariate analysis, they are used for the diagnosis purposes and the prognostic purposes. So what are the most common type of multivariate analysis? There are 2. One is the multi-logistic analysis. Other is the proportional hazard analysis. I will give you a little example from that. This was back in 2009. There is a study, risk factor for a first thrombotic event in antiphospholipid antibody carriers. a multi-center retrospective follow-up study. They use a multivariate logistic regression analysis. They conducted in 2019 to find out the risk factor for the first thrombotic event in antiphospholipid carriers. Then same group, same cohort, might be they will add more. They have done the prospective study to assess the risk factor for a first thrombotic event in confirmed antiphospholipid antibody carriers. First, there was in the positive carrier to evaluate the efficacy of prophylactic treatment. Now they have done they applied a different statistical technique. First, they do logistic regression, then they use the survival analysis, Cox proportion hazard model. From the same data, it means from the same data, you can do multiple studies. If you have a lot of these variables you have included in that. And I could not put a slide over that. There is a famous heading, a murky world of the sample side. If you need it, I can share the articles. The guide. So these are I will tell you a little bit about that. The regression analysis. There is simple linear regression, multiple linear regression, logistic regression, and then multiple logistic regression, Cox proportion hazard model. It depends upon that what sort of question is it is. Whether you have a continuous or categorical outcome, or you have a very continuous or categorical variable. So you can learn it. It's not difficult to understand. It's just you need to discuss with the statistician that I have this question. He can apply the analysis which is appropriate for that. You need to study that, and once you study that, once you learn that, it will be far easier to conduct that research. Now here I will give you a lot of why I put this slide. When I was back in 2017-18, at that time of 15, there was a new agent for the hepatitis virus treatment came, Veltasavir, Sovosovir, Veltasavir, Deltasavir, and they were giving them showing the doctors, the pharmaceutical companies, these survival curves. No one knows about that, how to interpret that. These curves, some will be going up, other will be going down. So you need to understand that gives us a hazard rate, a hazard ratio, and the Cox proportion hazard model is used in that. This is the most common analysis which is used in particularly in cardiovascular slides and in research as well, and in the oncology research as well. So now they have gone down to what is called RMST, restricted mean survival time. This is the new technique, and there are a lot of articles. I can share those as well. And now this is the technique, because when one variable change its value while doing on the analysis, so we have to address that. So therefore, this analysis come up. Now, here I will come up now a little bit of the more of the critical appraisal of the surgery and the randomized control trial, or the analysis of these RCTs. There are two trials: surgery versus non-surgical treatment of lumbar spinal stenosis randomized control trial, expertise-based randomized clinical trial of laparoscopic versus small incision open cholecystectomy. I could not find any article where they have done a laparoscopic versus small incision open cholecystectomy, though it was open cholecystectomy was very popular 2 decades ago. When laparoscopy came, we do not see any of study. If they want, there are a huge number of patients who they can do it. Now here, in the randomized control trial, the number of eligible patient was 5,119 for the spinal stenosis. Allocated to the surgery 87%, allocated to the physiotherapy 82%. And in this 50% of the people they crossed over, who were given for the physiotherapy, they refused for the physiotherapy, they switched to the surgery. And what they did, that in the analysis phase, they use the same number, 87 and 82, though they did not get the same treatment. Who were allocated physiotherapy, they switched to surgery, and some of them who were given surgery, they got the physiotherapy. They refused for that. So how will you analyze these patients? They didn't get the surgery and they didn't get the physiotherapy. and 50% is crossover. It's the 50% people if they're crossing over. So we have to, they didn't get the same treatment which they were given. So what we'll do in that? In the other one, the allocated number of patients in one group was 183, other group was 172, and the analysis phase was 177 and 156. Rather than here in this one, there was crossover, but they analyzed whom they were allocated. So what is this called? This is called, here is the flow chart for that. That you allocate a treatment A, then you allocate, then you randomize the patient. Then one got that was applied for the treatment but didn't receive it, and some after getting the treatment he lost the follow-up. So and eventually the who completed the study, the number is different. So for that we use the call intention to treat analysis, that you will include all those people who has been signed one group. You have to analyze in the similar group. Whatever happened during the study time, you will have to analyze in the same group. If you start it once they are allocated to the treatment but did not get the treatment, then you can do a modified intention to treatment. If they receive the treatment, it is called as treated, and if they have completed, that is called per protocol. So this is why we are doing the intention to treat analysis is because we want to preserve the effect of randomization. Once they are randomized, you cannot switch them to the other side. So this is the primary analysis which you do in the all the superiority trials or trials. That is called the intention to treat analysis. You will not be considering doing the modified or as treated or per protocol. But in non-inferiority trial, you will have to do the modified and the intention to treat, as treated and the intention to treat analysis. What is the impact on the result section? In the result section, it is a flow diagram which you are seeing, that if you do the intention to treat analysis, in that you may not find any difference. But when you do the per protocol, there will be at least 50% of the difference between them. So that will distort the results. So you need to know when you are critically appraising the paper. A lot of people, the author, they say that we analyze by the intention to treat analysis, but when you dig into that, you find out that it was not the intention to treat analysis. It was either the modified intention to treat analysis, or it was per protocol, or it was as treated. So now other question is, how will you deal with the loss to follow-up? So if there is around 5% of the patient, they have lost follow-up, they are okay, probably. But if there are more than 20%, then it threats to the validity, called the internal validity of the study. So always think about, and when are you designing your study? In small studies which are conducted in Pakistan, you don't see the loss to follow-up. But in all the major trials, you have some sort of loss to follow-up, and you need to address at the design phase that how we are going to deal with that. And there are different techniques for that. And loss to follow-up, they have a different effect on the results. So if the sick, they come out and healthy dropped out, then if treatment effect will be different. And if from the healthy dropped out as compared to the sick one, and are opposite to each other, it will distort the result as well. So we need to find it. We need to look at that as well while critically appraising the paper. So now, most of the time that the results section, they are presented as the odd ratio, relative risk, absolute risk reduction, and this and that. Then we count the number needed to treat at confidence interval. The main important thing in that is that we need to find out what is the control event rate. I mean, what is the event rate in the control group, and what is the event rate in the experimental group? It has a huge impact. Because if someone there is a control event rate is lower in the control arm, it means the result will be distorted. If there is a control event is higher in the control group, it means there will be different result. Here you can see that when you measure the relative risk reduction, it is the same, but absolute risk reduction will be quite different. Because the control event rate and the event rate, it gives you a different result, because the baseline risk is different when you are doing the absolute reduction analysis. And when you are doing the relative risk reduction analysis, it does not encounter the same the risk while in the analysis phase. So you need to decide about that. For example, there is a famous study that when they did warfarin and rivaroxaban analysis before, the half of the people, their INR level was subtherapeutic. So it means their toxicity, they were not in the therapeutic range, so there was less bleeding as well in the trial, but at the same time, that does not show the same the therapeutic efficacy. So since then, there has been a lot of discussion after that. So we need to look at that what is the controlled event rate and the experimental event rate. Now there will be a little bit about the randomized and systematic error. So random error, if you have a higher number of sample size, you can diminish that. But if it's a systematic error, it will stay in that. And these are the potential confounders in the observational study more so. It is also called the measurement bias as well, particularly in the case control study, but also in the cohort studies as well. So it is also called the differential and misdifferential classification. If simply saying that if your measure while in the case control study, if the cases they have been 20%, they give us a wrong answer, and they are switched from no to yes, or they are switched from yes to no, it will produce a non-differential misclassification. With that, the rate ratio will go down, and it will distort the result. So it takes little time to explain this concept. It's just I'm mentioning it. So it occurs when the people who are exposed and who are not exposed. If someone has a misclassification of exposure in the case control study, it will distort the results significantly. And most of the time, it takes towards the null finding. Similarly, when the sensitivity of the exposure and the specificity change, it's also changed the results as well. And now, why I put this slide, effectiveness of allopurinol and reducing mortality time-related bias in observational studies, because in Pakistan, there is a lot of discussion. Every single patient who comes with the aches and pains in the body, the rheumatologist, general physician, orthopedics, always they measure the serum uric acid level. And then they say that, oh, he has, and people they say, and the doctors say that, the people particularly, they say that I have a uric acid problem. And they consider it's a gout. I was looking at all this. This is a very good article to read. So in all those observational studies, there is a what we call it bias of misclassification that has distorted all those results in the allopurinol group. So we cannot. Therefore there is a discussion that should we still use the observational studies for the decision making, or should we rely on the randomized control trial? So therefore, this discussion will be keep on going, and still, once there will be good analysis techniques, hopefully then we will be able to address these biases as well. This is my favorite slide, which I read it back in 2005 or 6. David L. Sackett, he is the father of the recent evidence-based medicine. He wrote this article, I think, back in 2005, and he was talking about the 1974. He is saying that it's the 7th time I was taking the basic statistical course. At that time, he was already doing the randomized control trial as well. He was doing the multiple studies, and he was attending this in London, and it's the 7th time he did this basic statistical course, and he was not sure that I will be knowing it completely. So the way forward is that we need to improve our workshops for that, and the work this should be done by the researcher who knows the clinical research, not by the community medicine and from the what we call it, from the medical educationist. Thanks a lot so far. Yes. If you have any question, I will be happy to answer them.
Thank you so much. This was a very nice overview, and I think I really like your last slide. And I think myself and perhaps a lot of people listening can attest to the fact that even though we keep learning about these things, but it always seems like that we have to learn more about how to critically appraise and how to understand all these biostatistical concepts. So thank you again for doing a very thorough overview of this topic. So I think now there are lots of questions, and in the interest of time, we don't have that much time. Dr. Umar Hayat is here, who's our panelist. So Dr. Umar, there are questions, and do you want to maybe?
Yeah, I think let's quickly address the questions we have seen in the panel. So someone was asking whether this webinar is available or recorded, and the answer is yes. And I think Waleed has shared in the chat box the YouTube channel where this presentation will be presented again. So the other question was from Zan Nadeem, and he is asking, can you please elaborate little on the Pearson and Spearman correlations and when should these be used? Dr. Usman, can you please comment on that?
I will go to the if the answer is in that, because they need to know the variable, what variable they are using. Pearson is now for the continuous and other is for the categorical. So it is in the first slide which I use it in the unpaired data. The bottom of that I wrote it that what depending upon what is your first variable, what is your second variable. It's very easy to use. It is self-explanatory in the table. Therefore, I put that table for all these statistical tests.
Thank you. Thank you.
Yes.
So then there is a comment from Tahir Bashir, and he is saying the careful study design is the crux of any research problem. So that was just a comment. And then we have another question from Anonymous, and he is asking how can we contact Dr. Mohammed Usman? So I think probably you can share Dr. Usman, your contact information in chat box. So if anybody is interested.
First of all, I tell you, I honestly speaking, for 6 years while I was working in Pakistan, I met the principals of the medical colleges in Lahore. I was begging to do these presentations, and first one they asked me in the neurosurgical department back in 2020, just the COVID started. I gave this lecture, and we planned for the critical appraisal workshops for them, and it was for 3 months. But then after that, I have to move to Pakistan, to over here. I will be happy to answer. It is freely available. Whenever they will ask me, I can do it, and I can present over there. There will be no, and even all the whatever I have spoken it, I have all the original papers with me from them. And if they're interested, I can share them the paper, the what we call it, the paper. They can use my email as well, and I'm flexible to give them the mobile number as well. I don't mind at all. That's my interest, that I want to teach them. That's it.
Thank you. Thank you very much,
Yes.
Dr. Usman. So the other question was from Sheikh Ahmed Gill, specificity and sensitivity. Sir, explain with an example, please. I'm a little confused. And
yes,
also
yes, sensitivity is when the test is positive and the disease is positive, test is called sensitive. When the test is negative and disease is negative, it's called specificity. So sensitive test you use to rule out the disease called SNOUT. Highly sensitive test, it rules out the disease. And highly specific test, it's called SPIN, it rules in the disease. So if you want to rule out the disease, you need a highly sensitive test. If you want to rule in the disease, you need a highly specific test. So therefore, I'm saying that this concept, to teach them this concept, for myself to understand this concept, I took long time. So if we have the data and we can, when we have an interactive session, it is more easily, we can teach them. For example, I give an example that rheumatoid RA factor, anti-CCP, that in general population, it is only 5% of the time it is present, but it's a highly specific test. Okay, in the general population, it is present in only 5%. So but its positive predictive value is again less than 5%. Specificity of 97%. In general population, positive predictive value is only 5%. So This is a complicated area, which, in short, sensitive test you do it to rule out the disease. Specific test you do it to rule in the disease. Okay, and so if for example you are doing the troponin, high sensitivity troponin, you want to D-dimer, they help you to rule out that disease. They are not a diagnostic test to rule in the disease. So they are the sensitive test. Specific test, for example, double stranded DNA, dsDNA, that is a specific test. That's not a sensitive test. So there is a very good article about this measure by Nancy from the I think from Harvard University in the radiology back in 2002 or 3. That's a very good article if they want to get understanding of that. I can share with you if you want. I can share with you, and it is a very self-explanatory as well.
Thank you very much, Dr. Usman. I think that was a wonderful presentation and very educational. I will say the one thing I just want to make a comment. I'm very committed to the trainings, and I strongly believe in trainings. So what we are doing is we will be setting up the training center, and believe me, every expat who would like to visit Lahore, we would love to invite him to do the presentation or training session. And we will announce it, we will publicize it. So I think we will be changing this whole landscape of the clinical studies. And Dr. Usman, you would be probably the one of them we will always like to invite.
Well, honestly, this I spoke to one of the principal of the medical colleges that I can bring a group from here in Galway University Hospital. When I did the diploma in that, I wanted to whole group. They said, okay, we just invite us. We will come over there. We will conduct the study. Half of the funding, they will get it from the university here in Galway. Would you believe it? Honestly, no one agreed to that. I will be, whenever you call me, I fully agree.
I think we need to acknowledge this fact, the work ethics or even the thirst for the knowledge, especially even our people who are working in Pakistan, they're busy in their own stuff. So this training center would be purely focusing on the education.
I would love to do that. I would love
Inshallah,
to do
it's
that.
a game changer, Dr. Usman, and you will
Inshallah.
see the objective is a very different here. And I'm doing this just for really want to give back to the country. And that would be excellent platform. So I think I'm going to give back to Dr. Sarfraz. We are a little over the time. Thank you for the really nice presentation.
Yeah. So thank you so much, Dr. Marhat, for discussing as a panelist. Before I end, I think it's one thing I see in the comment. There's a comment from Dr. Rosina Shahadat Khan that she wanted to add a few points. I don't know if she's able to unmute herself, and maybe if you can just take like 1 minute to add whatever points you would like to add. And then after that, we will end. Of course, a big thanks to Dr. Mohammad Usman Aamir for his presentation. Waleed, is it possible that Dr. Rosina she wanted to share a few points, and can we ask her to do that, or it's not possible?
Can you please repeat the name?
Rosina Shahadat Khan.
Okay,
I think she mentioned that she wanted to add a few points. So I just wanted to if 1 minute, I know we are over time. I just want to give her 1 minute to say something if she wants to say. Yes, Dr. Rosina, just very briefly, can you please, we're already over time. So.
Bismillahirrahmanirrahim. In which of the favors of your Lord will you deny? I want to thank you all the officials concerned, especially Dr. Mohammad Usman. It was quite informative and very comprehensive presentation on your behalf. As I am Associate Professor Community Medicine and Head of the department as well, and in this profession for the last more than 11 years, did my MS, PH, as well as MPhil Community Medicine, now PhD scholar in this research process. All your concerns strongly agreed to it, but a few points that can add to whatever you are passionate about is a reality check to the situation. And the reality check is this, that I have recently completed my systematic review. And the background was this, that I shortlisted the RCTs that followed the consolidated standard of reporting trials, and all the RCTs that were shortlisted that were from the journals from ParkMedNet. 44 journals were shortlisted having all those RCTs that were fulfilling the inclusion criterion. And starting from 2010 till 2019, 781 articles were shortlisted. My concern is this, that we have improved a lot. We have improved a lot as far as the quantity of research is concerned. But concern was this of my supervisor, Dr. Zuhaib from Khyber Medical University, that whether we have improved the quality as well. So the whole of discussion is just very well paying the attention that why we are still restricted to cross-sectional study designs, not even case control or cohort. Why we don't talk about the RCTs? The basic issue is funding, and the other issue is this, that we are missing one important thing, that is the baseline. The baseline is this, that there are standardized reporting guidelines. Can you imagine that my systematic review, it was purely was done by me, and I did the review 3 times of 781 articles. Can you imagine that only one of the articles was reaching that point of 68% adherence? Just one article out of 781, and the mean adherence to the consolidated standard of reporting trial remained 45%. This is the misery of the situation, that the base is very important. The way we start conducting the process, that demands our attention. And the important thing at the end is this, that a community medicine persons are mostly short of funds. We have the ability to design the project, but the person who is doing the intervention is clinician, can do the intervention, so that short of funding can be. And the third important thing is the role of biostatistician. That is very important. I am also the managing editor of PPMJ. The role of biostatistician is very important and very vital. A person who is just trained and doing the basic biostatistics, as you have just pointed out in one of the articles, that he has tried again and again and did the basic courses. You cannot replace a person who is like a master's in biostatistics or PhD biostatistics. So we
okay, Dr. Regina, I think I must interrupt you. We are already way over time.
This was my last
thank
concern.
you so much for
our teamwork is required.
Okay, thank you so much for your excellent points. We really appreciate it. I really have to end because we are really way over time. Dr. Akhtar Hamid has also joined. Walid, did he wanted to say something or?
No, that's thank you. I know it's a matter of time, and I just wanted to say that I mostly represent the SIN part of it, and then I'm based in Toronto. Your point has been very excellent. The 2 things is very short and quick is the RCTs are being neglected in Pakistan due to the funding and period. So if we could do on it more and more, and people like you come forward, that would be great. Thank you.
Thank you. Thank you so much again. And thank you for our panelists. And thank you again to Dr. Mohammad Usman Aamir. And thank you for all of our participants for taking time. I know it's late at night in Pakistan, at least. We have early here in the US. So again, thank you everyone for joining and sharing your thoughts and comments. And we will make this available on YouTube. And then again, as Walid has pointed out in the chat, that we will be providing certificates for attendance from now onwards. And like always, thank you so much, Walid, and your team for technical support. And we will come back with another webinar next week. And until then, take care and thank you.
Thank you.
Bye.
I think take Dr. Rosina probably for one of the seminars as well, if she is willing to volunteer. Thank you.
Thanks very much.
Thank you.